Thank you, everyone. Can you see my screen? Just making sure you're seeing everything.
Yes.
Thank you for joining us today for the third installation of this town hall series, Your Story, Our Science, brought to you by the ALS Therapy Development Institute and Her ALS Story. Today's we're talking about how we can improve the ALS diagnosis process. And before we get started, I wanted to do a big thank you to our sponsors who make this possible. So Cytokinetics, Biogen, Mitsubishi Tanabe Pharma, InSource Services, Novartis, Unicure, Ionis Pharmaceuticals, Regeneron, and Eledon Pharmaceuticals. And I'm going to click through. So you all know Carol. My name is Emily Daunt Beatty. I am the Associate Director of Community Education here at ALS TDI. I've been with ALS TDI since 2017, starting out as a social media specialist. And throughout the years, I've learned a lot about our work, and I'm really excited for this new venture for me to get out and start telling more people in the community about the work happening at ALS TDI. So our mission is to develop and discover treatments for everyone living with ALS. We are the largest drug discovery center, comprehensive drug discovery lab in the world, focused solely on finding a cure for ALS. We are the first ever nonprofit biotech for ALS, founded in 1999 by the Haywood family when Stephen Haywood was diagnosed at the age of 29. His brother Jamie realized there wasn't anything for him and he decided to do something about it. And ever since then, we've been growing and our science has been developing since then. And we put 87 cents of every dollar that we raise into finding treatments and cures for ALS. And ultimately, we will not stop working until everyone has effective treatments and cures for ALS. So now I just want to do a quick shout out to the ARC study because you're going to hear a lot about it today. So the ARC study is the ALS Research Collaborative. It is something that we have built ALS TDI to empower people with ALS to become partners in ALS research. Anyone living with ALS or asymptomatic gene carriers can participate. You decide what data you're going to submit, and Danielle's going to talk about a lot of the data today and how we've used it. And it can all be done from home. So it's fully remote and it's free to participate. You also have access to your data via an online portal, and all of the information collected in the ALS Research Collaborative is de-identified and shared with researchers around the world through the ARC Data Commons. So everything that you all submit through the ALS Research Collaborative is making a huge impact in ALS research. And I also wanted to introduce our partners for this event, Her ALS Story. Their mission is to raise awareness that ALS impacts young women diagnosed before 35 and to provide a community for them to connect, learn from each other, and find support so they can live their best lives. Their primary objectives are to create a network for young females living with ALS to lean into and to provide a platform to advocate together for better treatment options. And we are so lucky that we have two of them with us today, Gwen Peterson and Atiliana Gibson, and along with three presenters from ALS TDI. And with that, I'm going to pass it off to Danielle Boyce, who can start digging into the data with you.
Awesome. Thanks so much, Emily, and thank you all for coming. First, I think I'm going to share my slides. Alan, would you like to give us a brief overview? I can run the slides of, let's see, from beginning. There we go. Of what we're actually collecting, and then I can talk about how I analyzed it.
You got it. All right, yeah. So these town halls are very engaging and take a lot of time. So I'm going to spend just a very little amount of time on the topic that's relevant for today. So if you want to learn more about ARC, go to arc.als.net. We have pretty broad inclusion criteria. A lot of people can sign up, and I just listed our aims there. And the little figure on the right are
Oops,
sorry.
sorry. Sorry,
I'm just
jumped again.
using the whole slide, I guess. The five main tasks are listed there, but the thing we're going to talk about today is actually just the intro survey. So now you can go hop over to the next slide.
Okay.
So this is our new enrollee survey, which is actually the first thing that participants have to complete after they sign up and consent to joining ARC. It's actually where we collect their names and stuff because we haven't done that at this point. But we're also collecting information about their current state and sort of where they are in their ALS journey. So you can go on to the next slide. It's a zoom in of this survey. So the first question related to diagnosis that we have is the status of the ALS diagnosis. And as you can see, the options listed here: possible, lab supported, probable, probable, definitive, and then carriers, PLS, and healthy volunteers for those who are not diagnosed with ALS. The first four items are the diagnoses, and so those are terms defined by the Ellis Scoreal criteria. Maybe some of you have heard what that is, but essentially it's a certainty-based criteria, as you can probably guess, that is based on the amount of regions of the body that are supposedly affected by ALS, and if there's upper and lower motor neuron involvement. And so these are we treat them as diagnoses, and so people come into the study usually receiving one of these terms from their clinician. So we have people put in that, and then if you go to the next slide, then we ask them about their first symptom date, roughly month and year. So the first symptom that they think was associated with their ALS, that location of those symptoms. So it can be multiple if it's multiple parts of the body. Then the first neurology visit date, roughly, and then first possible ALS diagnosis date, meaning when somebody has ALS considered, but there might need to be more follow-up visits or referrals, or maybe another examination has to be scheduled. So that is in progress, and then the formal ALS diagnosis date is sort of the formal one when somebody is officially diagnosed with ALS. And so you can see we capture a bit of the journey here, the timeline of it. And if you go to the next slide, if we want to improve this process, right, we have to collect data on it and be able to understand and interpret it. So of course, one of the questions we ask is, as researchers at least, is does time to diagnosis tell us anything about the type of ALS that somebody's going to have? And in this case, it's sort of like a retrospective interpretation of the diagnosis process, right? We use data collected in the ARC study and then look back and see how long it took somebody to go from their first symptom to their first visit to their first, or to the diagnosis, right? And in our study, we see that people usually takes about a year, I think, between symptom onset to diagnosis and then another year to join the study. But that requires us to understand, it requires people to fill out and give data, right? Like that's not in the moment data. It's sort of after. So the other question is, what are the other factors that influence diagnostic delay and diagnostic timing? And we capture some of it, but not all of it. So there are other obstacles that have nothing to do with ALS that affect this process. So for example, those are like clinics visited, and that can be the quality of the clinic or the capacity of the clinic or the neurologist involved, right? Those all affect how long it takes for somebody to get diagnosed. Issues with scheduling, just basic logistics. That's either on the patient's part or the clinic's part. Maybe getting exams scheduled is hard specifically, but not seeing the doctor. And then if there are other pre-existing conditions or sort of history of conditions, so some people have injuries that they've had previously in their life, and it might send people down, or it might send clinics down on a path that is related to that injury, thinking whatever symptoms being presented are related to that injury, when in reality it could have been ALS, and how often clinics are prone to do that. And it all sort of stems, of course, from us not understanding enough about ALS. So if we want to get to better, to shorter diagnostic timing, earlier diagnoses, we need to sort of collect as much as we can and understand as much as we can about the diagnosis process and the journey. So I think I'll turn it over to Danielle now to give insights from the ARC study and from HAS.
Yes, thank you so much, Alan. That was a great way to set this up for me. And I really want to get across to you two things today. One is just some insights that we have learned from our data set that's nearly 1,500, and in this case, about 1,500 participants are in this particular analysis. But also to highlight the need that we have for larger sample sizes in specific populations, particularly younger people and specifically younger women, and why it's so important to be represented when we do these statistical analyses, and how sometimes the story that might be told by a research paper, for example, doesn't ring true, doesn't feel representative of you, and maybe that's because there's not enough of you in the sample. And so I kind of want to go behind the curtain and show you how that works in statistics. And so I've been on a bit of a journey understanding this data set. And so think of this as just you're kind of getting a glimpse into really the beginning of our journey in analyzing this data about diagnostic delay. So this is the population that we looked at. People with an ALS diagnosis who reported in our surveys the age of their onset, or their date of onset and their date of diagnosis. So also remember that if somebody didn't fill out all of these surveys, they wouldn't be included, and that could introduce bias too. So we don't know enough about them to include them in the analysis. But this is a very good sample size overall, 14 almost 1,500 people. And so this just shows you, it's called a histogram, and there's probably data people here who are getting a kick out of this right now. But this is a histogram, and so each bar represents the number of people. So you see right up the middle, right before this 60, so like 58, so more than 120 people in our data set had at age 58 or so, age of onset. That's what that means. And so you can see at the earlier ages, 20, look how few people, 20, 30. We have lower numbers, age of onset in the younger, and then of course in the much older, lower, that would be expected. And so it's pretty normally distributed, and it looks like what you might expect. But we have fewer on the side here, the younger side, and that also is something that you would expect. But there's challenges when you don't have more people in certain categories, because it makes it harder to understand and draw conclusions about them. But we're doing our best to understand that. And actually, this has been a wonderful opportunity for us to understand where we need to do better in terms of reaching out to folks who can participate. I also looked at male and female and to see if there is any kind of really obvious age of onset difference, and not really. Not really here. So the mean age of onset is 53 for males and 53 for females, and so that's pretty even. But the sample size, we have 900 males and 598 in here, so fewer females. And then I wanted to look at months from symptom onset to diagnosis. Now, as Alan said, we collect from the time you went to the doctor to diagnose. Oh, I see Gwen has a question.
It's Dr. Boyce. This
Yes.
data was collected over how long?
This has been collected since 2016. Is that right, Fernando?
2014.
2014.
Excellent.
2014. Yep. And that's actually a great question, Gwen, because that's going to come up in a minute when we talk about years. So you set me up perfectly for the next thing. So then I looked at the months from symptom onset to diagnosis. Now, Alan mentioned we also, and one more thing. If you want to raise your hand, and if I don't see you, somebody shout out and tell me. And also, if you need to use the chat and we'll read it. It's fine. We'll just read the chat if you have a question. So it's okay if you aren't able to use your microphone, okay? All right, back to this. So then I wanted to look at months from symptom onset to diagnosis. This is very broad, and it doesn't reflect what happened at your doctor's office to the time you were actually diagnosed, which is also important. But I just went with like the big picture, broad, from the time you had symptoms, for whatever reason, how long did it take you to get a diagnosis? All right, and I looked at it male to female. Now you can see this. This is a skewed distribution, and actually, I cut this off for the purposes of this slide. There's actually some that go out, and this is months, like 200 months reported, or more, like a lot. There's not too many of them, but like some were really extreme outliers. But you can see here, this is the same thing, frequency, how many people reported this. And you can see here, these are months, not days. So we're talking, 10 months, 20 months. There's a lot of people who are going, now we're 30 months, 40 months, and so on, right? And so the mean, which is the average for men, is 16.4, and for female is 15.6 months from your onset to diagnosis. So it seems that it's lower for females, but remember that's a mean too. And so if you have more males with like larger, like a couple of males with a really big number, then that is going to make the female part seem smaller than it actually kind of is if you were to normalize and control for that. And so I wanted to show you this also so that when you see the studies presented, you can understand the kinds of ways that they can be misinterpreted, and how that often happens in women's health in particular. And so number of months from onset to diagnosis, the median is if you put all the numbers in a line and you pick the one right down the middle, that is sometimes a better measure because of how that dispersion works, where you have the extreme one side or the other. But if you put right in the middle, that's 11. That is still too long, right? But there's no significant difference statistically between males and females on that part. Again, though, it's influenced by the number of people you have, the number of males with long delays and so on. So that's not like a definitive, there's no difference. It just means in this particular sample and how we're looking at it here. But what factors overall influence this long delay? So one thing I wanted to look at, in addition to other factors, was Fernando and I were talking. He said, I think that it's gotten better over time with advocacy, with awareness, with the internet. I think it has gotten better over time. And so I plotted this out. So this is the mean number of months to diagnosis, over time. And this actually highlights here on the left that high, there's some people who reported their symptom onset. This is symptom onset, not when they enrolled in the study and were diagnosed, which would be different. But when they felt like their symptoms started was way back when. So you had people in 2014, 2016 who had these symptom onset way back in 93 and so on, but not many of them, right? But some people reported very high. And so you do have these outliers, but as you go along, you can see that there's been a general trend, but we still seem kind of stuck. Not setting the world on fire here, over 2021, 2020. Like we're kind of like stuck at that 11 months or so, and it's not really budging, but it has improved. So what I found was that with every passing year, overall, the time from symptom onset to diagnosis was statistically significantly reduced. So that's a win for advocacy, but it's true for both sexes, but women seem to be benefiting slightly less than men. But when you go behind the curtain and see what we're really talking about, we're talking about a matter of weeks, not a matter of years or months of improvement. We're talking 2 to 6 weeks, I'm finding, right? So I looked at other things too. I looked at limb onset versus bulbar. I put age in. So younger age was correlated heavily with diagnostic delay. It was statistically significant. And that kind of rings true for what a lot of folks have told us here. When looked at alone, but it was a weak correlation, maybe because there was some noise from those outliers and other things. But when we control for year of onset, age is no longer significant. That is not because it's no longer significant necessarily, but because we don't have enough young participants to power that analysis. And so the age seems to be correlated, like highly correlated with the year. So the younger people in earlier years, had very long waits, and then the ones in more recent are fewer. So they might have a shorter wait and it just drags things out. So my point of all of this is, yes, there seems to be a correlation between age and how long it takes you to get diagnosed. The year of onset is significant, but if you look at the overall model, it's only explaining about 10% of the why. So this is the beauty of statistics. So even when you do find this potential predictor, then you look at how much does it actually explain? Not actually very much. There's a lot of these other factors like Alan mentioned. Do you have a genetic, family history? Your proximity to the hospitals, all these things about disparities. Maybe there's an interaction between sex and something, age and something, right? And so it's really important when we look at these statistics to understand the importance of the size of your sample, who's in your sample, and how much of explanatory power do these statistics have in the overall. So just because you have a p-value of, you'll see these have a significant p-value, doesn't mean it explains everything. We're seeking the truth here. And so to that end, I wanted to know of people who maybe aren't in our study, what are they experiencing, these young women with ALS? And so we asked them, how many months passed from the appearance of your earliest ALS symptoms until you received your official ALS diagnosis? And this is informal outside of the ARC study, just informal conversation. And so responses range from 17 to 48 months. Now, we only have a handful of folks over the last few years who are on the younger side. We only have like under 20 probably who are under 40 years old or so. So a lot of these people probably aren't who answered this probably aren't in our study. And most respondents, though, experience delays longer than 2 years. So this is what I mean when you see a study or somebody analyzing data like this, and then you say, but wait, like I waited like a long time. That doesn't ring true for me. And that's because of representation or lack thereof, right? Approximately how many months passed from your first doctor's appointment until you received your official ALS diagnosis? 3 to 34 months from your doctor's appointment. And so to me, this is really compelling about the specific issues around the younger and female, her ALS story, audience. Even after seeing a doctor, delays of up to 2 years were reported. So we can do better. What are these factors? How do we identify them? How do we translate that out to the folks who are doing this work and trying to make these improvements on the clinical side? Did you experience any challenges during the diagnosis process, like misdiagnosis symptoms being minimized or ignored? Yes, a lot. I mean, a lot more than I could even possibly put on here. But I kind of grouped them up. Misdiagnosis, did a lot of dismissive comments, delays in EMG or specialist referrals, which prevented you from getting that definitive diagnosis. Like a lot of people felt like they were suspicious and that things were going on, but they didn't get you into who you needed to see to get that diagnosis. And some were told that it wasn't ALS or their symptoms were unrelated. Actually, a lot of people were told that. Or they waited, just waited, weren't sure, just waited. And so we asked, is there any advice that you would offer others who are going through the diagnosis process? Be persistent. Don't be afraid to change providers. Document your symptoms. Advocate for tests like EMG that you might hear about in these Facebook groups or other places when you're talking to these folks for her ALS story. You hear that. You advocate for that. Seek out top specialists. Find support networks. Talk to a counselor for emotional support. Bring someone with you to appointments when possible. This is both for documentation purposes, but also when you get news that is hard to hear, you don't want to drive home by yourself. And that's what we heard. We want to make sure you're supported. Trust your gut. You know your body best. Push for faster answers and ask questions proactively. And that includes, I'd like to say, when you see data that you don't agree with, you push back on that too. Go ahead, Gwen.
Even send your questions to your care team the night before so that they have time to look into.
That is a great point. And they appreciate it too, because then they're not rushed. Then they've had some time to think. And so the key themes and takeaways, I'm sorry I couldn't give you like the answer, in a week of data analysis, but we are doing better, but we have a long way to go. Just because we're better than we were in 2014 doesn't mean 11 months median is okay, right? Diagnostic delays are common even after seeing doctors. Dismissive attitudes and misdiagnosis hinder early intervention. Self-advocacy and persistence are critical, which I think is all what her ALS story is all about. Hope and support from others make a meaningful difference. And ALS TDI needs more data from younger people to make our analysis truly representative and to really be able to share these stories. And I need to find ways to share these stories outside of these big analyses where you're mixed in with everything, right? I need to find ways that we can analyze data that tell these stories better of these subpopulations. There are tools and statistics that can be used to tell stories with small samples. We do it all the time in rare disease. And so, in addition to increasing how many folks we have in this age group, I think those two things will help us to do a better job. We have integration with electronic health records now, so we can pull things back from your history, learn things about what happened to you in the past, and better flesh out these stories. Because we can't possibly ask you to answer every single question, that could possibly have something to do with it. We just need to do better, and we really appreciate your partnership on this, because it's been really this last three webinars have been a awakening for me in how to do this work better. So I'm gonna pass it on to Atiliana and Gwen, and I'm gonna check the chat because I saw a bunch of a bunch of chats come up, and I'm gonna answer as many as I can. So Atiliana, I'm giving you the floor.
Can you hear me?
Yes.
Hi, my name is Tiliana. I was diagnosed 2 years ago. My symptoms first started at like the end of 2022. I was newly pregnant with my daughter, and I kept experiencing falls and like a tingling down the back of my left leg. And my OBGYN was first thinking maybe it's sciatica due to the positioning of my daughter. But then the falls started to happen, and they were growing increasingly more as my pregnancy progressed. So she sent me to have a MRI, I want to test, and everything came back normal. And my falls, the tingling in my leg just wouldn't go away. So they then switched me from a regular OB to a high risk pregnancy team. And then I went and had blood work done, another set of MRIs, CAT scans, and there was another test they did, but I can't remember what it was. And after the last test, that the high risk pregnancy doctors sent me to see a neurologist who did another set of MRIs, CAT scans, blood work, and everything kept coming back normal. So she was like, I want to do one more test to see what is going on so that we can figure this out. So my testing started in like the end of November, beginning of December of 2022. And then in April of 2023, I had a EMG done because they couldn't figure out any other tests to do. So we did the EMG on like a Friday afternoon, and I could tell that something was wrong by the facial expressions of the neurologist that was doing the EMG. And he just basically told me, this is a conversation that you and your neurologist needed to have. So I went crazy with Google over that weekend, and the Google searches were coming up for MND, and I didn't understand what that meant at the time. And the following week, I went back in to see my now neurologist, and they explained to me that what was wrong was that I had ALS. And I got the diagnosis April 26th, and I was 7.5 months pregnant with my daughter at the time.
Tiliana, how long did that all take from up until you were having early falls and symptoms to time to diagnosis?
7 months.
And last question from me. When your OB referred you to a neurologist, did she explain why she was doing that?
Because all of the tests that she was doing were coming back normal. And she believed that something was wrong. She just couldn't tell me what it was.
Tiliana, I'm just really sorry that you spent, your pregnancy with what sounds like a rambunctious, wonderful little person back there,
Yeah.
worrying about all of this. Gosh. And Gwen, or does anyone else have any questions for Tiliana? Or Gwen, do you want to tell your story either way?
Yeah, I can jump in. Everyone raise your hand, use the chat, ask questions. So it took me 18 long months to receive my diagnosis. I felt we were on a previous slide, we were talking about sort of other reasons for delays, and mine was a misdiagnosis of anxiety, which is, a real epidemic in healthcare wide, the anxiety misdiagnosis. Um, and along the way, I saw several doctors, well, I went straight to my primary care doctor when I was similar to Tiliana, having balance issues, gait issues, repeated falls. So, like most of us do, went to my primary doctor. She was the one who said, I think you have too much going on. It's anxiety. Again, the falls continued. So I saw a series of doctors after that. It really wasn't until I established care at a university level hospital, where there was a specialty ALS center, a multidisciplinary clinic, and that's where I started really getting answers. And as you know, most of us don't go to a MDC. And a lot of our MDCs are in major cities. And most of us live outside of major cities. So it's just one more reason why the diagnosis takes so long. And one thing, Danielle, I put into chat is in the future, it would be really interesting to explore, like, um, you know, how much time post diagnosis it takes to establish care at a MDC and get on FDA approved therapies. Like, these delays to diagnosis cause even more delays. And so, yeah,
Yeah.
I'll pause there.
That's a really good point, Gwen. And I was just thinking about this as a good use of our electronic health records data. Like I'm always looking for like the best use cases for that. And one of the things that I'm finding is when you participate in the ARC, you have the option of importing kind of automatically your electronic health records data. It's a pretty easy process. And then I get all of the data, which is a lot. But with a lot of people will have data going back 10 years or 5 years. And so I can follow that diagnostic odyssey. You know, I can follow when you went in and you were asked this doctor and that doctor referred to this person and that person. And then I can follow the first study that that neurologist referred you to because it's in their note. And so they'll say, well, this person expressed interest in this study, or I, decided to put them on this, this and offered this clinical trial or so on. So that would be a really great way to document that in a way that wouldn't put the burden on the person with ALS to fill out surveys and all those details because it's typically in there. We can usually see even if we get the EHR data starting at their first neurology visit, they usually have some mention of what happened to get them there. This person was referred to me by this doctor. They said that they started having symptoms at this date, and then they went to this doctor and that doctor and that doctor, and now they've seen me. And so that's something that we can definitely kind of prioritize as a timeline for sure. That's a great idea, Gwen. Thank you.
When the journey, almost the jump from a diagnosis of anxiety to a clinic, what happened in between there? Was it you self-advocating? How did that all happen?
Yes, yeah, it was me it's too much self-advocating. So I was given a choice by my primary care doctor. As the falls were continuing, she said to me, well, I could refer you to a neurologist. I could, we could rule that out. And
Like if you wanted to be dramatic, she would do it for you?
yeah, yeah. And also, like, we look to our, providers as subject matter experts. Like, sometimes we want to be told, especially by subject matter experts, what to do. So I was in this really precarious position. Like, okay, what the heck do I do? Yeah, and so I did see just a general neurologist at a private practice. Um, and Carol, the world works in crazy ways, so it wasn't until I got a new psychiatrist who watched my walking, really listened to my symptoms. She was a woman, she was great, and she said to me, I'm going to refer you to a neurologist at UCSF, which is sort of, higher level uh, care.
Yeah, I think you're right about self-advocacy is needed, but it's also a burden. You know, Atiliana, you're pregnant with this was your first child, you know, you should be advocating around that. And I think you're right. You want to be able to feel what to do, you know.
Yeah. And Tiliana,
It was. He's my yeah. It
it's
was my second child.
Well, God bless you. You
I'm
have your
just
hands full.
I'm wondering if Tiliana and any others on the call, like I see Andrea just put a comment. I'm wondering if you feel like you've in the vein of like self-advocacy. I'm wondering if we're feeling like we've got to know the right questions to ask in order to get answers. Tiliana, did you feel like you had to ask questions and kind of drive that yourself?
I do. I feel like if I wouldn't have continuously said something's wrong, it's not like I didn't feel like it was sciatica due to my pregnancy. I knew something was wrong. And so I felt like I had to keep saying that. And it was like they almost looked at me like, you're making it up. And I knew I wasn't. So I feel like self advocacy is important, but sometimes it can be a burden.
Yeah, it is. And I'm wondering too, of people who are on here today, and anybody can pipe up either through the chat or, unmuting. Um, how many people are pretty sure they had ALS before they were given a diagnosis, and how long was that period of time? Eventually with effective treatments, that period of time is going to be very, very important. How long was that for you, Gwen?
It was a few months, I would say 3 months, and Dr. Google kind of helped in that time. But Carol, that's another great point. We've got to remember a lot of these FDA approved therapy, promising, treatments in the pipeline. They're most efficacious within the first couple years. Um, so
Yeah, one comment following on Carol's point. Like if you can feel that you have ALS, science should be able to measure it, right? So um, we have to work as a field to get to that point to where there's something that we can measure how what you're feeling and how you're feeling. So capturing that information about how you felt and when you felt it, and then capturing samples and as much data as we can through electronic health records will help us get there. Like one of the programs that we're trying to learn from through ARC is actually, as we've started to enroll more and more people in the study that are asymptomatic mutation carriers. And we're collecting samples and data from those individuals. Now, we don't want any of those people to ever convert, right? We want them to stay healthy as forever. But if, God forbid that happens, we have an opportunity to capture that and see what we can measure in those individuals. And then for individuals who join the study really, really early in their diagnosis, there's opportunity there too to look at different symptom types, right? So a person who might come in with symptoms in their right hand, right? There are elements of them that might seem asymptomatic that we can measure things. So we might be able to get digital measures from their legs or from their voice, and we can get that sort of really, really early signal that we can try to extract from. It's very hard to do, but with new technologies, that's going to be more and more possible, right? To get these biomarkers that can get us to an earlier diagnosis. So that's like, at least on the research side, those are a few things that I think we can do and that we're working on, and others are too, like the dial study. There are a lot of great studies out there that are working in these directions. And then on the other side, and I think it was like, Rick commented about it, really teaching more than just the neurologists, like the other folks in the world who might be exposed to things that could look like ALS. And so this is something where I'm actually impressed by something that ALS Association is doing. It's called, they're coming up with this Think ALS tool. And it's really just a simple like rubric of like, here are things that anyone can look for where like you can trigger this might be ALS. And I'm happy to like share a link about that. And then another group, sort of on a global level, the ALS MND Alliance, which is kind of a group of groups that's international. is working hard to try to share that same type of information, not just in the United States, but globally, because these are like looking at signs and symptoms. That's something that you can do in any clinic. You don't necessarily need to have, like an MRI machine, right? Or the ability to measure biomarkers in blood for that type of thing. So in all of this progress and all of these programs, though, they've come because of advocates that have said we need this. The status quo is not good enough. So we need to like keep doing that. So I just kind of want to express my gratitude to everybody who's out there doing that work. You're making a difference. You're making us better.
Fernando, how close or how far away are we from having, validated diagnostic markers, whether it be, a blood-based biomarker, a speech, or yeah.
I I don't know how close, right? I know we're making progress, but I can't say there's an amount of time. I can tell you that there are multiple fronts where we might be making progress, right? So, at the molecular level, obviously there's neurofilament. That's not great diagnostically because neurofilament shows up in lots of different diseases. But in ALS, it is often a lot higher than in ALS mimics. And so I do know, like, I know a few neurologists who are saying, you know what, like, if I'm on the border and the neurofilament is high, that gives me a higher confidence it's likely ALS. If it's low, I don't rule ALS out. It still might be ALS. But if it's high, it makes it easier for me to make that call. But we're looking at other things too as a field. Increasingly, for those of you maybe you're aware, we think a lot about this protein called TDP43, particularly in sporadic ALS. TDP43 stops working the right way. And when it stops working the right way, you see changes in other molecules called RNAs. They get misspliced. And so there are lots of different ways now to measure that. So it's early days on those, but that actually might be the type of thing that could look like a diagnostic and a pharmacodynamic biomarker. So that's making progress. And then the digital, right? I know we've made massive progress in collecting the necessary data. I think what's about to kind of engage is the ability to analyze those data to look for these signals with newer computational and AI tech. So I don't know how much closer it is, but you get the sense the same way, um, you know, we could think about a target before, but we couldn't hit it because we didn't have ASOs. Like ASOs came. This might be the type of thing where a new technology comes in and makes something that seemed far much closer, much more quickly. I hope that answered your question with a non-answer.
I had a question actually. I don't know. I don't see any hands up, so I don't want to speak over anyone. But when you're talking about self-advocacy and the importance of that, and it was really compelling to me, remembering who was answering these questions, which are women in their 30s or younger. And I know this is a problem in every disease area. Women put themselves last on their list. This is one of the busiest times for women when they're in their 30s and 40 for many women, not all of us, but many of us. I have 4 kids, and if I'm lucky, if I look in the mirror once a day, because I'm so busy. And so if I have to make a bunch of phone calls, it's going to be all my kids' phone calls first, or if I'm working new in my career, I'm thinking I'm in my 20s and working in my career, all these other things that might be going on, your caregiver responsibilities, your parents you take care of, all your families. So even, so there's lots of reasons why women in general feel this burden. And I'm wondering, Gwen and others, if you can comment on in your conversations with others, do you feel like you really have to remind people that they're worth it, that they should do this, they need to follow up? and also thinking about how disparities kind of come into this, meaning what if you are working in fast food, and you just can't make a phone call and all of this is going on and you have all these responsibilities, it's very hard to self-advocate for many people. So anyway, that was a lot, but just thinking about how all of this affects our ability to get that diagnosis if you don't have time or energy to push.
I think there's also trepidation around like asking questions and, oh, I don't want to come off too pushy, or I don't want to bother my doctor. The doctor only has 10 minutes, he or she is in and out. Like, no, to what we were talking about earlier, it's like we have to do our research, ask questions. There's certainly a line between, being inquisitive and pushing back. It's not like that at all. I think I think the good physicians respect us when we sort of come in, ask questions, and have done our research. So I encourage I encourage so much research and questions in advance, and you are never being a burden or pushing back.
I think that's an excellent point. And I think, I mentor a lot of students, and for all of them, not just the women, but especially, with young women with children, I often find myself saying, listen, you're not a bother. You have the right to ask questions. You have the right to take a break. You have the right, if you didn't get your question answered, and that's in any setting, right? If you didn't feel like your question was answered, you have to remind people, I think, in general as a society.
Any
Yeah,
setting.
any setting, I think we should all feel that we have the right to ask questions that, and also I think there's a differential between you're talking to a physician or somebody with a
Yep,
PhD, and it makes you feel like you
absolutely.
don't want to bother them. So I think that's really important messaging as well. Barbara, you had a question.
Yeah, maybe it's more of a comment. Um, I'm 75, so I'm not, you know, tasked with children or things like that. But I don't really care about pushing and annoying people. That's their job. They get paid for that. And because of arrogance or I know better than anybody else and disregarding what I was talking about, to everyone's point who's experienced this, I lost probably a year of proper diagnosis and treatment. And I'm very angry about that. And I'm not in my 30s and I don't have children to worry about, but I'm still pissed off. And I don't really care about annoying these folks. That's their job. Too bad. If you feel that I'm annoying you, then you're in the wrong line of work. You shouldn't be dealing with human beings. That's my rant for the day. Sorry.
Well, I think that's a fair one.
That's a fair one. I think more people need to hear that.
I'll be
Tiliana,
glad
you
to
had your hand up.
I'll be glad to say it whenever you need to hear.
Yeah, I need you on my phone, and I just hit that whenever I need it.
Absolutely.
Tiliana, did you want to say something?
Yeah, and I felt like because I was pregnant at the time, that even when I mentioned that it could be ALS or another form of MND, my OBGYN just kind of dismissed it like there's no way that is what it is. And maybe had she listened to me, I could have been diagnosed sooner than 7 months, and it would have been a safer delivery for my daughter as well, because
Yeah.
they made me deliver early, and she was intubated as soon as they cut her out of me. So I feel like there was a lack in things because I wasn't being listened to. And I know that this is more of a neurology specialty, but I feel like every doctor, nurse, they should all be informed of what ALS is and how to help their patients.
Well, you're right. And, I think, and by the way, I recognize that it's 4 o'clock. If anybody, I know some of our team needs to pop off, I'm happy to stay on because I have one more question that I hear from people about, if you don't mind. So please understand if you have to go. There are so many differentials, right, during a pregnancy on top of anything else, everything else. So I'm wondering, of the symptoms that you reported to your doctors, was there one that rose above the noise? Was there one that made them go, oh, okay, now,
I think I honestly was more the high risk team that did more listening than like telling me, no, it's not that, no, it's not this. And it was because I was explaining that I had ALS before I knew that I had ALS, and it was like I was explaining that I would be walking and my leg would just give out. Like it wouldn't, it would kind of almost drag, my foot would kind of drag in a way, but it was making me fall. Like I have scars on my face from falling
oh
over and
God.
over and over again for 7.5 months. And I think it was the fact that I was describing my leg just giving out for no reason that made them go, maybe something really is wrong.
Yeah, I think, and probably since you were pregnant, it was hard for them to get out of their, frame of reference, right? You're
Yeah.
always going to use your own frame of reference to try to explain something. And,
Mhm.
Lynn said, you're right. 95% of PCPs have never seen someone with ALS, and his had a patient. And Barbara, I think it's interesting, and it speaks to how long it took you to get a formal diagnosis, that it was temporal deterioration of your gait that finally convinced someone to move you forward onto a specialist.
Yeah,
Yeah.
and that actually was the spinal surgeon, and he tried his best to figure out what was going on. Um, but the handoff to the first neurologist was really didn't work, and as it turns out, she's the head of the ALS clinic at the Hospital for Special Surgery, which I think my cat could have done a better job, but there you go.
Get it. And we see a lot in the chat. Thank you.
Carol, we're saving this chat somewhere because I'm making my statistical analysis plan based on all these comments. I need to update what I'm doing. And I
Yeah.
said to Gwen, let's maybe think about a repeat, an update to see where we got with all of this. Keep me accountable, some of these analyses.
Before
Yeah, these
we
are great comments.
Yeah, these are awesome. I'm reading through them live as they're happening too. Thank you for sharing all of that because you have people on here who want to do something with it. We don't know that we can do something about it, but perhaps we can analyze data in a way that can be compelling to clinicians to help them to get you to a diagnosis more smoothly and more rapidly.
Yeah.
Um, is there anything else anybody wants to say, rather than chat, because you're welcome to chat, as you do it, before we start to conclude. I can't wait to read that chat again myself because it's going so fast. Okay, I want to make sure too, I neglected to introduce some of the rest of the ALS TDI team earlier. I want to introduce the development team, Courtney Mish, Melissa Payne, Michelle Dupree, and Glynis Murray. There you are. These you will hear from these guys. We want to hear your honest feedback about this conversation, ideas for other town halls. We do these because we want them to be what you want. And poor Danielle, because when we say we want to do what you want, it means work for her, but she's delighted to do it and is learning the whole way. So
Happy to do it.
thank you.
It's so important to have use cases that matter. That's everything. I have a sea of data. The important thing is which research questions really matter, and who better to inform that than people who actually have lived experience, who've been through it. So it's the best thing for me to be able to do this. I never feel my work is more meaningful than when I'm responding to requests from the community.
Awesome. Emily, anything else we need to do?
I think that's all set. We're going to send out the recording so you can watch it again. We'll try and answer any questions. The development team will be reaching out. If anyone posted something in the chat that was not answered, they will make sure that they get a response for you. And we really appreciate everybody joining us for this whole series. And if you didn't join us for the first two, I highly recommend watching them. I'll make sure that we include the recordings of the first two in the follow-up email.
No, and Jamie, I so agree with that. That's where a lot of people end up, right? Sorry, Emily, I got distracted again by the chat. Thank you. All right. Thanks, everybody. Have a good rest of your day.
Thank you,
Great to
Carol.
It's great to see everybody.
Emily. Thank you, Danielle. Thank you, Angelina. Thank you, Gwen. It was wonderful. Appreciate it.
Thank you,
Thank you,
Peter.
Peter.
Peter, it would not be a town hall without Peter
That's
Jennings.
right. That's what I know. It's true.
Thank you, Emily. Thank you, Carol.
Good to see you, Gwen.
You too.
Bye, guys.